Every time I see this opening slide, I'm like,
Mhm.
what is she writing? I want to know the rest of the word.
The dot.
The RA what?
I jokingly, what is that technically called in punctuation? An ellipse or something like that? But
No, I think she's talking about the little girl who's writing on the
oh,
chalkboard.
the little girl. I see. I thought
Yeah.
you meant my dot.
No.
Yeah,
Oh, the
so
ellipsis. I was like, what are
yes.
you talking? Okay.
Oh, the RA. Yeah, is it an I? It just doesn't have the lines yet, or
So I've analyzed this and I think it's either rain or rainbow because
that's
of the
what I thought.
cloud right over her head.
That's
Yeah.
what I thought too. I thought the same thing. So this is almost like a Rorschach. Like I feel like it could.
Yeah, absolutely.
So is it rain? Is it rainbow? Let me just check because
I thought she was writing rad because this is such a rad program, but she's probably way too young to even know that word or what it means.
Thought she was writing roar for the dinosaur, but my O and my A are inverted. So
wait, is there a dinosaur on the thing?
Yeah, right in the middle.
Oh,
And
I think I'm not seeing it because of my. Oh yeah. I see that.
she's
And
kind
the
of little. She may not
airplane.
know how to spell roar either, so
Yeah.
it's possible.
Yeah, she could still be spelling roar.
Yeah. Roar.
All right, well, we're a little past noon, so I know we may still have some folks joining us, but I want to go ahead and get started because I know we do have a lot of information to get through today. I am recording the session, so everyone will be able to have access to the slides and then also to the recording that you can share with your team. And if there are practices that aren't able to join us today, I will share the slide and recording with them. Again, I just want to thank the Ohio Department of Health and the Ohio Department of Mental Health and Addiction Services, and also the Ohio Academy of Family Physicians. They have been great partners to us on the project, and always want to thank them for all the support they give to this work. Just to let you know today's agenda, we're just going to check in and see who we have on the call. And we do have two wonderful speakers with us today, and I will let them, when it gets to their slides, introduce themselves. But we're going to do just a deeper dive into safety planning, and then also talk a bit more about behavioral health prescribing in primary care settings. And then I have a few reminders. If we don't get to those because of time, I'll send those out in email. And then we will just do a quick wrap up. So I'd like to just see who we have on the call. I believe I saw Dr. Fuller join us from Associated Pediatrics.
Yep, I'm here.
Welcome and thanks for joining us. Do we have anyone on the line from Pediatric Associates? All right, Fairfield Primary Care. Fisher Titus Pediatrics in Norwalk. I think I saw Brandy.
Yes.
Yes. Hi.
Yes, we do. Hi.
And Brandy, were you with us as well? Oh, I see their microphone is not working. That's Brandy. So great. Feel free, Brandy. Any questions or anything you need to say to Chad, and I'll keep a check on that. Do we have anyone from Medina? Anyone from Christ Hospital? Do we have anyone from Fisher Titus Milan? Or Fisher Titus Wakeman?
I'm here. Can you hear me? It's Dr. Canfield.
Yes. Hi, Dr. Canfield. How are you?
Good. And I may have to drop off because I've got 3 meetings going on at one time. So I'll watch the recording, but I'll try to stay on as long as I can.
Okay, great. Thank you. I believe I saw Dr. Rankin from Mercy Health.
Yes, I'm on. I'm following along.
Great. Thank you. Do we have anyone from New Carlisle? Anyone from Suma Barberton? I believe Karen is with us.
Yes.
Great. And anyone from Tri-City Avon? And I believe I saw someone join us from Mount Carmel.
I'm on. Kristen is Jasmine.
All right, great. Thank you for joining us. Is there anyone else that I missed? Or anyone from ODH, OMOS on the line?
Hi, we're here from Christ Hospital.
Oh, hi, welcome. Thank you for joining us.
I'm here too. It's Jen from ODH, Jen Casatano.
Hi, Jen. I did see you sign in. Thanks for joining us today. I'll make sure you all also have the slides and the recording.
Thank you.
All right, so as I mentioned, we have two guests with us today, Dr. Snyder and Dr. Harris, who will be talking to us a bit more about sort of after the screen, like you do their screenings and then kind of what happens after that. What are some options that you might be able to do more with in the primary care setting? So I'm going to let Dr. Harris kick us off, and I'll turn it over to you. When you'd like me to move to the next slide, just say next slide and I'll advance the slides.
Okay, and for those who haven't worked with me yet, I actually prefer interruptions so that we can have questions answered when they come to you, and I'll let you know if we're going to cover it in future slides, but the information's fairly dense, so hopefully if you want to unmute or put something in the chat, it's okay. All right, so just thinking about the basic approach to primary care of mental health. We have these now routine universal screenings that you already know about, how to diagnose and assess severity, using the screenings as appropriate in primary care, how to actively intervene is what we're going to discuss a little bit more today, and talking about goals, and then how stabilizing before tapering off, things like that. But I think the best thing to do is if they're not getting better, the principle is do something. So, follow up monthly until their symptoms remit or until they're near recovery. You can collaborate with the team, you can step up therapy or step up the treatment, consult with a psychiatrist as well. And if you don't know anything about psychiatry or mental health, you can always focus on brain health is the big thing with nutrition. You guys do this anyway, nutrition, sleep, social interactions, that connectedness. These are all therapeutically helpful things to do. And as the pediatrician, you can definitely guide the child's focus of what to do next as well. Next slide. Just briefly, I'm not going to touch on this too much, but with the PHQ-9 modified for adolescents, or even just the regular PHQ-9, the difference is 2 questions at the end, but for the most part, if the child has the first 2 questions with a 2 or a 3, and the total is around 5 to 9, it's considered a positive test by most standards. There's probably something there you should look into, but really over 10, the sensitivity goes way up for an actual diagnosed major depressive disorder. I just wanted to highlight the 5 to 9 group because I think this is probably where primary care can intervene the most and make the most impact. But it's often the one that we ignore the most. So we'll get there. But really over 10, I consider to be moderate major depressive disorder. And if they keep sticking between 5 and 9 every time you give it, it's a major depressive disorder, mild severity. And then severe is considered anything over 20. Next. So we have a 12-year-old presents for the annual routine health screen. The caregiver indicates concerns for irritability and poor grades this quarter. No social determinants of health risk were identified. And you notice before walking in that the PHQ-9 was 15. The interview revealed no concerns for trauma, no evidence of suicidality. Just click again. And after you finish asking questions, he does meet criteria for major depressive disorder. You use your SIG ECAPS interviews, points of the different DSM criteria for major depressive disorder, and establish that the diagnosis criteria is met. And you think, looking back at your PHQ-9 score, it's moderate to severe intensity. So now what? All right, so after he's here for the routine physical, but after you explain how the irritability and academic decline, along with some social functioning issues that have happened as well, that you reveal that it supports this diagnosis, and you do recommend intervening immediately to reduce the risk of recurrent major depressive disorder, the family is like, okay, let's do this now, and we'll come back for the routine health screen because he had his 11-year-old shots like last year. Go ahead. So one of the things you can do so let's say you did want to continue, or they wanted to continue with the routine health screen, you've established safety, and I know you're going to get into more details about that with the next speaker. But let's say safety isn't an issue, and you give them their lockbox and say, if they're ever around, like teenagers around, potentially lethal items, it's not a good idea to have them out. They're pretty impulsive. Here you go. If they're ever around those things like guns or alcohol and medication. But let's think about health. What can you do? These are things that you can do to help yourself. So self-management is one of the definite primary care interventions. Thinking about different, like picking one goal, not listing all of the things that they should be doing, having the kid say, which one do you think would help your mood the most? Let them pick it. Let them come up with the tiny, tiny little behavioral activation goal. Like if they're not showering, then let's say you get in the shower once a week, or increasing it by twice as many times this week as you did last week. Something very small. What are the barriers? How are you going to do it? And then writing this down. The other interventions can be explaining what depression is using the cognitive model, which is how our strong emotions are relating to our thoughts that are often automatic and are relating to our behavior, as well as sensations in our body as well. Thinking about how to teach the problem solving technique. Okay, so you have this giant problem at school. How are we going to, like, what techniques can you do to solve the problem? And then going through that step analysis, and happy to go into it further, but I'm just going to do an overview right now. Behavioral activation, self-regulation. So if you're distressed, what do you do in those moments? How can you help dial down that intensity yourself? And focusing again on brain health. Sleep, I think, is the most primary thing for mental health, especially during this pandemic. It has been getting restful sleep, and adequate sleep is important. Next. So looking at the guidelines for adolescent depression in primary care, these were updated in 2018, called the GLAD PC guidelines. And there's a Journal of Pediatrics endorsed it, and the AAP has endorsed this as the method for primary care, taking care of youth. And it breaks it down pretty simply, but the algorithm is really big. I kind of focused in on this one little tiny section of treatment. How do you treat those 5 to 9 mild depression kids, and actively supporting them instead of watchful waiting, which was the previous recommendation. They actually recommend active monitoring. So let's have that self-care success. They pick something and then you follow up every week or two until 6 weeks, and then you see them back in the office and reassess with the PHQ-9. It doesn't have to be you as the primary care person doing this, but it could be a care coordinator, a nurse, it could be the therapist, but really this active engagement. And if they're still meeting criteria for depression at 6 to 8 weeks, then they get kicked into this moderate depression, or actually they get kicked into like the direct intervention or evidence-based intervention for treating major depressive disorder. If you've had no training, it is perfectly reasonable to consult with a mental health specialist, like I'm talking about a psychiatrist for the medical management, or definitely referring to a therapist for other interventions as well, and we'll get into that. But if they're heading towards severe, or if there's any lethality present, or any comorbid alcohol or drug abuse, or suicidality, obviously, then treatment with a specialist is preferred, and consulting with one if you can. So then if you hit the button again, it might circle. Yeah, so what you can do in primary care. So obviously we can do medication. I think everybody knows that when you see a psychiatrist coming, that's like, what we'd handle, but initiating medication and or therapy in primary care is appropriate. Using evidence-based treatments, and then monitoring the symptoms. So if the psychiatrist starts it, monitoring, I think FPC is here, yay. So monitoring symptoms for adverse events or like side effects, things like that. That's what you can do as the primary care doc if the psychiatrist is managing it. But then considering like ongoing consultation, especially if they're not getting better, or to kind of better understand how long to treat. And at the bottom, it gives really good guidance about what to do for those active monitoring, about clinical management, and then how to monitor for changes and emerging events in the bottom in that fine print. Go ahead. So the evidence-based treatment, cognitive behavioral therapy, and interpersonal therapy for adolescents. The GLAD PC has this little paragraph, breaks it down beautifully, and it's helpful to understand what it is so that you can see if the kid's actually getting evidence-based treatment, not just supportive care. Next. So the best thing to do when you do refer to a therapist, remember you are still the medical manager of the child, not the therapist. They are there to provide the treatment of psychotherapy, evidence-based psychotherapy. And if there's any resistance or if the family's like not going, really collaborate with the professional who's treating them and kind of better understand what the dynamic is before just automatically referring to somebody else or like discounting that kind of therapy. Go ahead. So the big three, this is actually why treating anxiety and depression is easier than ADHD, because there's like 3 medicines in primary care that are the main ones to pick from. And they're FDA approved for some type of pediatric anxiety or depressive disorder in youth, and are preferred by the AAP in terms of guidelines for primary care being able to initiate and manage. Either with or without support of a psychiatrist. Fluoxetine, which is FDA approved for major depressive disorder in 8 years old and up. Escitalopram or Lexapro is FDA approved for 12-year-olds and up. And sertraline, it's not FDA approved for depression, but often if there's comorbid anxiety, it does have some solid evidence for pediatric anxiety disorders and is an alternative option to the first 2 SSRIs. And the reason why this one is there as well is because there's really good evidence, or actually there's FDA approval for obsessive compulsive disorder, which in my opinion is like a really extreme form of anxiety in kids ages 6 years old and up. And there's actually some possible benefit of like depression with using sertraline. The box warning, actually, when I first started these talks, this was a big deal. And now I think a lot of people are like, okay, we get it. So fluoxetine, Prozac helps. Okay, treat it with CBD, it helps, is bottom line. Venlafaxine or Effexor is like the medication that actually prompted the box warning for suicidality. Next. All right, and this just goes into a little bit more detail. And basically, I wanted to just highlight, this is fluoxetine. It works great for anxiety and depression, especially if they're comorbid. It is a great first-line medication, period. For depressive disorders, I usually do it in the morning. It tends to be a little bit activating, meaning like they may have some trouble or restlessness when they're trying to fall asleep if they get it right before bed. But otherwise, give it in the morning. And it has a really long half-life. So if they miss a dose or 2, it is super forgiving. However, if they miss a dose or 2, they may think they don't need it. So that frequent follow-up, especially in the beginning, is incredibly important to ensure that adherence is happening and to help tweak it until it's actually working consistently. There is very little to no withdrawal with it. And when it's combined with evidence-based like CBT, it actually has the greatest reduction in depressive symptoms. It's a strong 2D6 inhibitor, and I can go into that later, but basically when combining with stimulants, it can make the stimulant side effects greater if it's in the, especially in the amphetamine side of the family of stimulants. And I see a question from Dr. Lazaron, is the sertraline better than fluvoxamine for OCD in children? Better is a tough word, but it's still first line in pediatric OCD for primary care. Fluvoxamine, actually, I'll get to that in a couple of slides, but because of the side effect profile is a little bit messier with fluvoxamine in particular, they do want some consultation with a pediatric psychiatrist as you're prescribing it if you're not familiar with the medication. Great question. So next slide. Escitalopram, excuse me, Lexapro is great. I think with starting that one at like either a 2.5 or 5 milligram dose, they can be given in the morning or the evening. It doesn't really matter. And then increasing it by 5 milligrams every 4 weeks until you have a sustained benefit. The maximum dose for that is 20 milligrams. And to think about it being as like twice as strong as citalopram or Celexa. But again, it's really preferred to have the escitalopram as a side effect profile is much better. And the QTC prolongation is less associated with this versus citalopram, where it's strongly associated with it. All right. And for sertraline, oh, just real quick, sertraline, because this is kind of the meat of it. Sertraline starting at 12.5 or 25 milligrams. It's like breaking that 12.5 or breaking the 25 in half is an appropriate starting dose. And this one is like, you could increase it by, 12.5 or 25, 12.5 for like the younger kids and 25 for the older kids, like over puberty. Is appropriate. Like you can even do that every week until you hit the lowest therapeutic dose, which would be around 75 milligrams. For most people with little kids, I might stop at 50 first, but really to see if there's a benefit for it. But you can keep continuing to increase it until they, if they're not having side effects, if that makes sense. It tends to be a little bit sedating or kind of making people tired. So splitting the dose, if it's over 100, tends to get rid of that like daytime fatigue piece, or you can just give it at night to help with sleep. This is the one that you do have to taper because it can cause a nasty withdrawal if you just kind of like stop it abruptly. Next. So if warning signs, if they think about self-destructive behavior, actually, I'm going to skip through this. The akathisia one is pretty interesting. It's rare with SSRIs. That's like the pacing or feeling the need to move. Next. There's another point. But the big thing with the SSRIs, especially with younger children, is if within the first few days, you notice some agitation, impulse control problems, insomnia, especially after a dose change, this is a sign of activation. And it looks like ADHD that they didn't have before. And you just dial the dose back down and wait a little bit longer before increasing the dose and try and increase it a little bit slower. It's just a sign that it's like too much of the medication for that kid. And it really does happen frequently in small children when you go with too big of a jump. But if they're fine in the beginning, but then at like 3 or 4 weeks, they start having like rageful irritability, pressured speech, behavior that's really bizarre, that's when we need to stop the medicine and call psychiatry, because that's really more of a concern for bipolar manic activation. Next. All right, so this 12-year-old dad actually did well with escitalopram. Mom didn't really know what dose he was on. So given family history, they wanted to initiate pharmacotherapy with the psychotherapy. And they prefer to start with Lexapro. So you started at 5 and then increase it to 10 after a week and refer to the CBT therapist at school. And I know that's a regional thing. I just made up the school part. Next. And then your care coordinator in your office checks in after a week. They got the medication. There's no suicidality. They just review like that self-care success plan that you set up. Get consents to talk to the therapist. Week 3, they check in again. Hey, how you doing? And mom reveals, hey, this kid, his stomach was really hurting after the increase and we didn't want to take it anymore. So we already have an appointment set up. So you see them in your office that he's been off of medication for 2 weeks. Now what? I know you guys have never seen cases like this. So they stop the medication before they get to you. I think preparation is the biggest key here, and common side effects are actually GI, and the stomach issues like feeling nauseous, like looser stools, are really common in the beginning. It should not cause pain. It should not cause fever. It should not cause vomiting or explosive diarrhea. Those are totally different things. Wait until the child recovers from whatever that is before resuming the medication. But these really do resolve. These like butterflies in your stomach resolve after 4 or 5 days because you have serotonin receptors in your gut and those downregulate, which is another reason why SSRIs are really helpful with irritable bowel. But the activation is the other reason. And again, if it's disinhibition, restlessness, and kind of really emotional, just decrease the dose and go slower. Kids with comorbid anxiety are not going to tell you they have comorbid anxiety, and they tend to feel all of the side effects more. So it's important to warn them that this can happen, all the kids, and then start at a very low dose and go up. Okay, next. Treatment failure, I'm gonna kind of skip. Are there any other questions that are coming through? Because I can keep talking if you want me to.
I
All right.
haven't seen any
Good.
more questions so far. I think when we move to the other speakers, certainly feel free to chat in additional questions if you have those for
Perfect.
Dr. Harris, and that would be great.
So as we're thinking about this kid who was on the 10 milligrams and they stopped, it's technically not treatment failure. It's like they were intolerant, so they didn't tolerate the escitalopram at 10 milligrams. So in my opinion, you can restart it, but at a much smaller dose, and see after you talk with them, it would be fine to do that. In this case, they're like, I don't want it. We're not doing it. So they switched. They wanted to switch. Therapeutic doses, and that's my little timer telling me it's been 20 minutes. Therapeutic doses of the medications are listed. So if you don't get to 20 milligrams, if they can't tolerate 20 milligrams, or if you're at 20 and they're not getting better, then that would be the lowest I would consider a treatment failure. If you're at 20, they're not getting better, but they don't have any side effects, go up to 30, go up to 40. If they're at 40 and they've been there for a month and they're not getting better, then you can call it a treatment failure and try a different SSRI. Same thing with these medications. So if you're at sertraline, I would actually even say 75 to 100 for a small child before considering it to be a treatment failure. If they could only tolerate 50 or 75 without getting activated, that's okay too. But for most of the kids, like even 10 and up, I would expect them to be able to tolerate the medication, and getting it up to like 100 to 150 would be appropriate. And then really 200 for most people if they're not getting a benefit. And I've seen actually a difference between 175 and 200 when I'm treating depression and anxiety. It's really interesting. All right, next. So you start off at the fluoxetine at a low dose, 5 milligrams, then go up to 10, and then a couple weeks later go to 20. That's that lowest therapeutic dose. I would stay there for another month and then check in again. Next, I think, yeah. So stay there for about a month, revisit, like kind of keep bringing them back in every month or so, 4 to 6 weeks, to see if they're tolerating it, if the symptoms are still impairing, or if they have a sustained benefit yet. Next. And that's what I would do. You can skip it. This is like what I would do if they're not doing well after 2 trials of SSRIs. I would start getting blood work and I'd call the psychiatrist if I were the primary care doc. Okay. And just to reiterate the different roles, this is important to set out from the beginning. So as the pediatrician, you're the medical manager. The therapist is there to provide the skill building, the interventions that are appropriate for management, like self-management, as well as behavioral activation, and kind of helping them like reframe those thoughts that aren't helpful. And that's really by a non-medical, like a psychologist or like a social worker, LPCC. It's not their job to tell you that the child needs medication or not. That's your job as the medical manager to continue to monitor and work with the specialist to better understand if they're getting better or not. If they're not getting better, if they're stuck, or if social anxiety is there, they're probably going to need medication as well to be fully able to tolerate and actually move forward, tolerate therapy and move forward and get it to a place where it's actually helping. Care coordinators are fantastic for these interim phone calls that are needed or that really help. And it helps kind of you manage the child as like a team more so than just the primary care doc. And that's it, I think. Pretty sure. Any questions? Great.
All right, thank you, Dr. Harrison. Again, feel free to chat in additional questions if they come up, and we'll keep monitoring the chat box. So with that, I wanted to turn it over to our next speaker, Dr. Snyder, who can introduce herself, tell you a bit about what she does, and then you can just let me know when you need me to advance the slides.
Okay, sounds good. Can everyone hear me okay?
Hear you great.
So I'm Dr. Snyder. I'm a pediatric psychologist at Nationwide Children's Hospital, and I work in our integrated primary care programming. And I'm going to talk a little bit more about youth suicide, including some of the interventions and things that you can do as a provider to kind of help ensure safety and really help prevent suicide. So first, I just want to put out a reminder that the topic of suicide can be difficult. And so make sure that you're taking care of yourself, make sure that you're, taking breaks if you need to and things like that. I'm going to turn my video off because I feel like I'm in borrowing an office and I feel like it's weird. So I'm going to turn my camera off for a moment. Next slide. So really my goals today is just really to kind of go over some of the statistics about youth suicide. I'm going to kind of breeze through some of these stats and the definitions, talk more about the role of medical providers in suicide prevention, and highlight some of those specific strategies that you can really utilize with youth, including safety planning. Next slide. Okay, you can just click, yep. So I just want to go through a couple of definitions. Really the first, it's really just important to kind of distinguish suicide attempts from suicidal ideation and self-injury. Suicide really is a death that's caused by injurious behavior to the self with that intent to die. A suicide attempt is a non-fatal injurious behavior to the self with intent to die, but really this might not result in any type of injury. Whereas suicidal ideation is really thinking or considering or maybe planning suicide, and this can be passive, where you have more of that thought but without a specific plan or method, or it could be more active, where there might actually be a plan, a specific method that the youth is considering using, as well as that intent to really carry this out. And then there's self-injury, which are these purposeful acts of physical harm to the self with the potential for injury or damage. But this self-injury is different in that typically there's not intent to die. And so this is like what we call non-suicidal self-injury. So they're trying to hurt themselves, but the intent to die or kill themselves isn't there. Next slide. So I just want to kind of briefly go over some of the stats that we have regarding depression and thoughts of suicide in our US high school students. And this is from a 2019 Youth Risk Behavior Survey. And we can see that around 40%, nearly 40% endorse feeling sad or hopeless for 2+ weeks or more, and stopped doing their usual activities or kind of impacted their functioning. About 15% made a suicide plan. About 20% were seriously considering attempting suicide, and right around 9% had actually attempted suicide. And so I think this is really just important to kind of put it in perspective and to kind of help as you're seeing patients, and especially in our network, we're seeing multiple patients a day, that if you're even just seeing, 10 patients in a session, probably at least one of those patients has considered suicide, and about 2 of those patients have considered attempting suicide, seriously considered attempting suicide. We also know that, most lifetime mental illness starts around the age of 14. And there's that difference or latency between symptom onset and treatment, which is about 10 years. So if most lifetime illness starts by age 14, most youth aren't getting linked with treatment until around 24 years of age. And what we really know too is that most youth referred for behavioral health treatment aren't really successfully linked. Only about 18% have one appointment with a behavioral health provider, and only 12% have more than one visit. And so this really means that the majority of our patients are not receiving that minimally adequate treatment, which really just further highlights the need for integrated care and trainings like this to really help educate providers to provide some of these evidence-based interventions. Because what we do know is that most youth are seeing their PCPs once a year. About 80% of youth see their PCPs about once a year. Go ahead, next slide. So we know that there is a problem of youth suicide, that this is the second leading cause of death in youth ages 15 to 24. It's also the second leading cause of death for youth ages 10 to 14. And we also know that this isn't just limited to youth ages 10 and up or 12 and up, that we do see suicide and suicidal ideation in younger children. And in particular, we have some stats about 9 and 10-year-olds with the rates of suicidal ideation was about 6%, and the rates of attempts was right around 1%. And so it is the 8th leading cause of death for children under age 12. And so it's really important to take those statements about suicidal ideation or thoughts about suicide really seriously at all ages, but in particular, asking it to those younger youth as well. Go ahead, next slide. It's also really important to think about suicide in minority populations. We know that suicide attempts for Hispanic youth ages or grades 9 to 12 are 40% higher compared to non-Hispanic whites. We also know that about 42% of LGBTQIA+ youth are seriously considering attempting suicide in the past year. And we know that suicide rates for Black children ages 5 to 11 has nearly doubled. We know a couple things in particular about the LGBTQIA+ community, and that youth who had spaces that affirm their sexual orientation and gender identity reported lower rates of attempting suicide, and that transgender and non-binary youth who have pronouns respected by all people that they live with and all people that they're coming into contact with attempted suicide at about half the rate of those who did not have their pronouns respected by anyone. And so it is really important to be asking our LGBTQIA+ youth about their pronouns and what their preferred names are, and really trying to get those respected by everybody, not only that they live with, but in the clinics that we might be working in. Next slide. So a couple myth or fact: someone who has thoughts about suicide is determined to die. We know that this is actually a myth. The fact is that most suicidal people don't want death. They really just want the pain to stop. And a lot of suicidal people are often really ambivalent about living or dying. And so we want to make sure that we're asking about this, and really helping to provide access to emotional support at that right time can really help prevent suicide. Next slide. Another myth or fact: most suicides happen suddenly without any warning. Again, this is also a myth. The fact is that many suicides are really preceded by warning signs that could be verbal, they could be behavioral, and it's really important to be able to kind of help create, as a support system, as a network, ways that we can identify these warning signs and really try and respond supportively, because we never want to ignore or excuse someone who is talking about suicide, even if it's presenting as a joke. Sometimes that talking about suicide can really be a plea for help, and those at risk will show warning signs, and it's really important that we be aware of them and respond. Go ahead, next slide. Another one, talking about youth suicide puts the idea in their minds. Hopefully everyone knows at this point that this is one of a big myths out there. We know that talking about suicide, asking about suicide, does not cause a person to consider killing themselves or to consider suicide. Bringing up this subject and bringing up suicide really directly and discussing it in a really open and sensitive way is really one of the most helpful things that we can do. And so we don't want to be worried or be fearful about talking about it, because we know that by asking about it, we can really help open the door for someone already thinking about it to tell us more information and hopefully prevent this suicide. Next slide. A couple more true or falses. Most kids think providers should ask them about suicidal thoughts, and parents don't think their children should be asked about suicide by providers. So most kids, actually, they want you to be asking them about suicidal thoughts. This is one of the really the only times that suicide is often brought up, and they might feel like they can't talk about it unless they're asked about it first. So it's really important to ask about it. And most parents do think that their children should be asked about suicide by providers. Over 70% thought that this should be a topic of conversation in the doctor's office. I will just give you a small caveat that this parent sample was really small. It was only about 50 parents. So interpret this with some caution. It might not be totally generalizable, and there might be some differences with races and ethnicities and things like that. Next slide. So the good news, suicide is preventable. Depression is treatable. Without treatment though, or without having some of these evidence-based interventions in place, a youth might begin to feel so hopeless that they even start to consider suicide more. And so it is really important that we're aware of some of these types of treatments and these evidence-based interventions that can be kind of implemented in a clinic-based setting. And Dr. Harris did a great job of kind of going over the medication management. I'm going to talk a little bit more specifically about some of the other strategies and evidence-based interventions that we can use. Next slide. So this acronym might be helpful. I like to just think about ACT to prevent suicide, really just meaning that we want to try and ask about suicidal thoughts and behaviors and do this with everyone in terms of screening for suicide. We want to complete a risk assessment for those who screen positive on those initial screeners or those universal screeners that we're giving to most youth who we come into contact with. And I'll talk a little bit more about some of those specific questions that you can ask to gather some more information about the risk. And then the treatment, which really is a safety plan intervention in that moment, so that we can at least try and have some ways for the youth, the caregiver, and the provider to kind of all be on the same page for things that they're going to be able to do once we let them leave the office. Next slide. So as I mentioned, we always want to take kids seriously when they're making a remark, no matter what the age or no matter how it was really phrased. And we want to be direct. We don't want to kind of skirt around the issue or kind of ask these vague, abstract questions. We really want to ask these direct questions like, have you ever wished that you weren't alive? Have you ever thought about being dead? Have you ever had any thoughts about killing yourself? And then going on from there to kind of get some more information about, well, have you thought about what you might do? Have you thought about a method? Did you actually think that this was something you actually might do or actually go through with? Have you ever decided when or how you might kill yourself, and getting more information about what that plan was, and maybe even what happened to help prevent that plan, or was it interrupted, or did they kind of self-abort that plan to kill themselves? And definitely trying to get some information about how frequently these thoughts are occurring and the timing, like the recency. So when was the last time we had these thoughts of suicide, or you had this thought? And when was the last time you actually hurt yourself on purpose or maybe engaged in a suicidal behavior? Next slide. So now to get to the meat of it, really the treatment that is recommended is this safety planning intervention. And it is important to note that this is an intervention. It's an evidence-based clinical intervention to really reduce the risk of short-term risk of suicide. It is a safety plan and intervention that's tailored to the patient and is used to prevent or really de-escalate a crisis. And this is the intervention that's really recommended by the Joint Commission and other suicide prevention organizations. It is important to note that this is not a safety contract or a safety, like a promise of safety. You may have heard that sometimes we would ask patients to sign this contract to say that they're not going to hurt themselves in the next 24 hours. And we know that that's not an effective intervention, and that the safety planning intervention is a lot more effective, a lot more efficacious. And so that safety contract or promise is not something we want to get into the habit of doing. We want to really go through the safety planning intervention. Next slide. And so there are some underlying tenets of this safety plan, and this kind of just supports the rationale for it. We know that suicidal thoughts and urges really fluctuate and change over time. Oftentimes that acute risk of acting on suicidal thoughts or urges or those impulses is typically brief. It could be that, maybe something happened that day, or there was some other type of trigger that maybe started and they're starting to have these thoughts of suicide. And really, this can often be like an impulsive act. And so we want to try and recognize these impulses, recognize these urges, and really identify those warning signs of when a crisis might be kind of building, so that we can act and really try to prevent action or prevent some of those suicidal attempts or suicidal behaviors. We also know that problem solving and coping diminishes during a crisis or in those times of stress. And so the safety plan really is trying to kind of lay out things that the youth, things that the support system can really do in those moments of the crisis, so that they don't have to think about what to do. It's all right there for them, and they have their go-tos that they can kind of just try and jump into. And again, that this should be individually tailored to the patient and the support system. So we don't want to be copying and pasting from one patient to the next. We don't want to just hand out an already completed safety plan. We really want to work through this with the patient collaboratively and with the parent or with the caregiver to make sure everyone kind of understands what the strategies are, what the tools are, and what this intervention is. And really what this does is it really helps patients and the support system one, recognize when a suicidal crisis might be developing and identifies those preferred coping strategies without the need to have to think about them or problem solve in those moments. Go ahead, next slide. And so I put the asterisk there because I think these are some of the most important aspects of the safety plan. Everyone on this call had been really educated about reducing access to means and storing it safe and making sure that firearms are locked up. But we also want to consider locking up medications and cleaners or chemicals. We want to try and reduce access to sharps like razors, knives, scissors, and then thinking too about belts or cords or other things that might be used for hanging attempts. And so those reducing access to means is really important. The next important thing, and I'm going to show you a picture of the safety plan after this, is to try and get some idea about what is their future orientation or some of their future thinking. And so one way to do this is to ask about two things or people that are really important to them and worth living for. Oftentimes this might be family, it might be friends, maybe it's a pet. I had one patient who wrote Capri Sun, and my job is not to kind of judge what those really important things are, but just to have us identify what those important things are and write that down for them so that they can kind of take this home and use this as a tool once they're discharged from the office. And then increasing some communication and supervision with the caregiver. Sometimes it's hard for youth to go to a parent or caregiver and say, I'm having thoughts of killing myself, or I'm feeling suicidal right now. And so sometimes an emotions chart or color chart can be helpful. And then giving the caregiver some specific language that they can say in that moment, because it's scary as a caregiver to hear your child or your loved one say this, and to really just offer that support that I can see that you're feeling super down. I can see that you're feeling in danger right now. How can I best help you? How can I support you? Go ahead, next slide. This is just an example of that Stanley Brown safety plan. You can see that the first step there is to really go through and identify what those warning signs are that a crisis might be developing. So what are the thoughts? What's the behavior? What's the situation that happens that really leads to these suicidal thoughts or to worsening depression or anxiety or those thoughts that it might be better off if I weren't here anymore? A lot of times this is, I isolate myself. I spend more time in my room. I'm withdrawing more. I'm not as social as I used to be. I no longer want to play Roblox, which is what I always used to want to play. And some of those warning signs can be really helpful for the youth to recognize, but also for their support system for their caregivers. The second step there is really to think about those things that they can do on their own to kind of help distract themselves, to kind of take their mind off of those problems, really without thinking about needing to contact another person. So this could be things like I'm going to jump on TikTok and watch a bunch of TikTok videos, or I'm going to play Roblox, or I'm going to take a bath, I'm going to draw, I'm going to play my guitar, I'm going to go for a walk with the dog, or I'm just going to go for a walk outside for a little bit of time. Those type of internal coping strategies that they can do. It could even just be, I'm going to take 5 deep breaths and think about 5, 4, 3, 2, 1 in terms of like a mindfulness exercise where they're naming 5 things they can see, 4 things they can hear, 3 things they can touch or feel, 2 things that they can smell, and maybe 1 thing that they can taste. Is that 5, 4, 3, 2, 1. And then thinking about the people or social settings that could help. So this could be friends, this could be family, this could even be pets. It could be, going to the park, going to a church. It could be a lot of different places or a lot of different people. And then step 4 is really thinking about who I can ask for help in terms of who are those adults that I can ask for help. And then step 6 just talks about limiting access to those lethal means. And then the one thing I think it's kind of cut off down there is that 1 thing or 2 things that is most important to me and worth living for. Go ahead, next slide. This is just an example of that, like kind of a color chart that I kind of use to help increase communication so that the system can be aware that purple means I'm doing really great, red means that I'm in crisis, and yellow, green, and gray are kind of more of those in between. And it can just help give that communication without having to kind of talk more about how they're actually feeling, and can help everyone really be on the same page. Next slide. Dr. Harris talked about behavioral activation, and this is another really common intervention that we use in the primary care setting. It is an established evidence-based treatment for depression in adolescents, and it can really provide some protective factors for depression and stress. So really the thought of it is that you're just trying to kind of identify some different things that the youth likes to do. And it could be fun activities. These could be responsibilities that they need to do. Could be something that would give them a sense of accomplishment or mastery. You can see there that through On Our Sleeves, onoursleeves.org, you can download some nice resources, including this Stress Buster Bingo, which really is using behavioral activation to kind of help increase those fun or pleasurable activities and provide that sense of accomplishment. And like Dr. Harris mentioned, this is something that you're maybe only doing for 10 minutes. Doesn't need to be, I'm going to work out for 60 minutes, or I'm going to clean my room for the next 2 hours or until it's done. It's really just kind of giving yourself 5-10 minutes goal and then kind of checking in and seeing where you're at after that 10 minutes has passed. Go ahead, next slide. This is just a behavioral activation worksheet that I often use in clinic. You can see that we're kind of helping to select those activities that they're going to do, trying to get active activities as opposed to more passive or sedentary activities, and really just listing them out, some of the activities they enjoy, some of the responsibilities that mean they might need to take care of, and then really having them think about what was my mood, my sense of pleasure, my sense of achievement like before the activity, and how was I feeling after the activity. And this is really using that cognitive behavioral framework where we're thinking that our thoughts, our feelings, and behaviors and actions are all connected. So if we're doing an activity we enjoy, we're probably going to be feeling a little bit better and thinking a little bit less negative or maybe more balanced thoughts. And so it's really helping them to practice this and help achieve this and kind of recognize what their mood is like. Next slide. I'm almost. This is a depression action plan that we also use. It's really modeled off of our asthma action plan. So if you're familiar with that, it might look familiar. We're just thinking about, I'm in the green zone, so I'm doing good. The yellow is my mood is worsening, and then starting to think about some of those things that they could do when they're in the yellow zone to maybe help get them back up to the green. And then if they're in the orange zone, which really is meaning that they're in trouble, these are some of those warning signs that might take place. And again, some things that they can use to kind of help intervene and provide some type of recommendation or strategy. And then the red zone is, of course, danger, which means that they need to get help now. This is really like made for our system here at Nationwide Children's Hospital, but I have a more generic one. And so I'm happy, I see someone already commented that they love this. I'm happy to share it with you so that you have these resources available to use in your systems as well, and I can make it more generic. And I think that's my last slide. Let's see. Oh, just some suicide prevention resources. That app there I have down there, My3, is a really great one. And so it's really great. It's using that Stanley Brown safety plan, and it's something that they can even do on their phone while maybe you're writing it down or typing it into the computer or the system. And it really just has it available there for them. Because one of the things I also ask is that youth take a picture of the safety plan, because I forgot my whole laptop at clinic today, which is why I was a couple minutes late. And so I know that they're going to lose this paper. They're not going to remember where it is, but they probably aren't going to lose their phone. So I like to either have them do that My3 app or take a picture of the safety plan so that when they need it, it is on their phone. They have it accessible to them right away. And that's it, I think.
All right, great. Thank you so much. So yeah, I did want to remind everyone, you will be getting the slides in the recording. And then Dr. Snyder, any of those additional resources, those templates, if you want to send them along to me, I can make sure that everyone also has access to those.
Yeah,
I think those
definitely.
were really great resources. So we just want to give a moment for any additional questions for Dr. Snyder or Dr. Harris that have come up. I know I've seen a few in the chat that have gotten answered, but feel free, any of your additional questions, to ask those now. All right, well, one great thing about the project is if questions or needs come up, you can always reach out to me about those, and we will get in touch with experts who can help us with any of those questions. Just a few reminders I wanted to give you about the project, as we've heard some things over the first month. Remember when you are talking to families about lethal means being accessible in the home, assume that the lethal means are there. So asking around if there are lethal means in your home, like firearms or medications, are they kept locked and away from youth? So not the questions of, do you have a gun, but asking and beginning the conversations more in a less questioning type of manner. We also had some questions about when older adolescents come to appointments alone. Again, you proceed with the screenings as you normally would. You also ask about lethal means as you normally would if a caregiver were there, and you can offer the lockbox. You know, how would your family be okay if you took home a lockbox for those lethal means today, just to help keep everyone safe? So we want to just mention that because some practices were experiencing that. Also a reminder to let me know when you need more resources. So lock boxes, you should have probably gotten some cable locks, and we are looking into medication boxes as well. We wanted to send you some medication locking bags, but they are too easy to get into. So we're trying to look at some options for boxes that are not as heavy for firearms, but you can use for medications. And then we do have your September charts. I just got those yesterday for your data. So I will be sending those out to you. And then we'll be talking through kind of what we see in those and what maybe some next steps are. And a reminder for October data. So be entering as you go. I know there were some practices who kind of waited to enter data until sort of toward the end of September, and that was a little more cumbersome. So it's best to enter the data as you have appointments and go. And then remember, at the end of October, I will be sending you that email to just verify your denominators for the month. So how many appointments you actually had. We use that again as your denominator to run your chart. So I just wanted to remind you about that. One of the other things we noticed in the month of September, you can see on the slide. So we were seeing about 52% of the time you were offering a safety lockbox. So that's telling us that that was a family that obviously did not have lethal means secured there was lethal means in the home and they weren't secured. So about 272 times the lockbox was offered. But out of that 272 times, we only saw about 17% of the time that the family accepted the safety box. So one of the pieces of sort of anecdotal information we were just wondering about is, you know, why are you hearing that families are not accepting the lock boxes as much as we would probably think they would, or just any information you could share about that? Does anyone have any thoughts on that?
We have a harder time with our virtual visits because then they have to come into the office and pick it up.
Okay.
Oh, sorry.
Go ahead.
I think I had talked about this before, but when I was first doing them, if the family didn't have a firearm or they already had a box, and then I was like, well, I offered it to them because we did say, do you need a lockbox? But they didn't take it because they already had one. They didn't have a gun. So I was putting no. And then after I talked to you about that, I changed that to NA. So
Okay.
I'm wondering if that's just other people have the same kind of confusion.
Gotcha. Yeah, so I can send out a reminder too, just in writing for everybody about that. That's a really good point. All right, and we'll see how that looks for October. But again, if you are hearing feedback on that, please let us know. I think that's very helpful and important information. So again, I want to thank everybody for joining us today, and also thanks to the speakers. This was just wonderful information that you shared. And I know it'll be really helpful as we continue with through the project. So thanks again, and I will be in touch with the invite for the December meeting, and then also to check in with you on your data. So thanks again. And again, please, if you have any questions or needs, don't hesitate to reach out via email.